Well, good afternoon, all. Can you hear me? Give me a thumbs up, maybe. Okay, thanks. Welcome to the ongoing spinal cord injury lecture series. Today we're going to be speaking on spasticity after spinal cord injury. You all have learned of spasticity in multiple venues, so hopefully this won't be brand new to you. We're going to talk through some definitions, talk through the epidemiology, how frequently this occurs in spinal cord injury and why. Then I want to talk through the anatomy and physiology, and we'll talk through the clinical evaluation measurements that we go through, as well as obviously management. So spasticity is first and foremost velocity-dependent increase in muscle tone. So we're going to see hyperreflexia due to disinhibition of supraspinal influences in the reflex arc. Remember, the reflex arc is Sherrington's spinal common pathway. We'll actually talk through that in just a moment. But basically, when you sustain an upper motor neuron injury, be it in the brain or be it in the cord, your usual inhibition is going to be blocked. So you have a disinhibition of the dorsal reticulospinal tract from the ventromedial reticular formation in the medulla. What does that mean? That means your reflexes can go out of control and your tone is no longer inhibited as the brain typically keeps it under good control. So we see upwards of 2/3 of folks with spinal cord injury will develop significant spasticity. Fred Maynard reported in 1990, by level of injury, about 90% of folks with tetraplegia will have significant spasticity, and about 46% of those with paraplegia will have significant spasticity. At the higher levels of paraplegia, almost similar to that you see in tetraplegia, but as you move down to the lower levels, we see less and less spasticity. Now, at the time of discharge, usually only about 25% of those folks being discharged with spinal cord injury will require treatment. However, at approximately 12 months, almost half of the people will require additional medical management of their spasticity. And the epidemiology that I just went through will make more sense when you take it down to the cellular level. So let's talk about that final common pathway. Basically, we're talking about organs in the skeletal muscle called muscle spindles. And those spindles will send information back to the cord and activate through interneurons, typically, the alpha motor neuron back to that same muscle. So what are the components of the muscle spindle? Remember that you have the nuclear bag and the nuclear chains as part of the muscle spindle, and these basically are sensitive to changes in length. So as you stretch this, it increases the number of afferent signals going up the 1A. These are afferent signals to the dorsal root ganglion, and they're going to synapse in the level of the cord. We'll talk through that as well. The chain also sends afferent information along type 2 fibers. So both of those will send information back to the cord. And then you're going to have a resulting, as we talked about, alpha motor neuron, but you also have gamma motor neuron influences. And that's going to be consistent with the activation of the alpha motor neurons, because the gamma motor neurons come to the ends of the muscle spindle and stimulate contraction of those intrafusal muscle fibers on both ends to be able to maintain a certain amount of gain within the system. So anyway, this is Sherrington's final common pathway. This is our stretch reflex. And under normal conditions, the stretch reflex is dampened by supraspinal inhibition. So as we talk through this, recognize that if we tap on the patellar tendon, basically at the knee, so from the extensor spindle, you have this, this activation basically that comes, and ultimately it's going to provide excitatory information to the extensor muscles And those are the results of excitatory postsynaptic potentials, EPSPs, modulated by glutamate, so that you hypopolarize the membrane and make it much more likely that this all or none axon is going to fire. On the other hand, or at the same time on the other side of the joint, the flexors, in this case the hamstrings, are going to be inhibited. And that's because they receive an increase in inhibitory postsynaptic potentials. Typically that's modulated by GABA-aminobutyric acid, to hyperpolarize. And so usually you're going to see a contralateral relaxation, if you will. So to the, in this case, the antagonist muscles. So we see activation of the agonist muscles and inhibition of the antagonist muscles. Now, look at this for just a moment, because this is going to be how we're going to significantly manage spasticity from a medical standpoint. We're going to talk about ways to either decrease the EPSPs or increase the IPSPs in the whole system to be able to modulate, if you will, reflex activity. So following spinal cord injury, you've got that initial period of spinal shock, and that may last days to weeks, rarely months, but occasionally months. And during that time, you have basically increased sensitivity of receptors. So your cholinergic receptors at the skeletal muscle are actually going to increase in sensitivity and number during this period of relative spinal shock. Ultimately, you're going to see hypertonicity. Potentially, we'll see motor recovery. We've talked about that in the last couple of weeks. So the question is all spasticity bad? And obviously, by the way I asked the questions, no. There is a certain amount of spasticity that can be good, but realize that spasticity is going to be increased because of that supersensitivity of those receptors that we talked about. And at the same time, that spasticity can, while maintain some muscle, maintain some bone, it can also be problematic and kick people out of their chairs, kick people out of their bed, keep them awake at night, and those types of things. So we need to recognize that sometimes it's bad, but not always. It's one part of the upper motor neuron syndrome that includes spasticity, hyperreflexia, weakness, and loss of dexterity. So how do we assess spasticity? That basically there are 5 different clinical domains that we can look at: the clinical history, the stretch reflex, the passive motion evaluation, the active motion evaluation, and then finally functional examination. And we're going to talk through each of these because it's important that you recognize each one as we go through there. So clinically, I want to know if this increased tone is having an influence on functional tasks. And if so, then I want to know what the triggers are, so that we can figure out, how can we dampen or modulate these as necessary. Sometimes the spasticity and spasms are associated with pain. Sometimes it's the pain likely that is mediating the increased spasticity. And so we're going to keep track of that. Obviously, if somebody is having poor sleep because of spasticity, then we want to try to manage those nocturnal spasms, and we have several options to be able to do that. So the Penn Spasm Frequency Score, this is unfortunately not something I see in a lot of our clinical notes, but it's something that I actually try to keep track of, particularly in the outpatient clinic, because it tells me how problematic the spasms are to an individual. So 0 is no spasms, 1 is no spontaneous spasms except under vigorous stimulation. So if I rub very briskly on the legs, for example, that might provoke a spasm. 2 is occasional spontaneous spasms, but are easily induced. For example, pulling a sheet across your legs might cause the person's legs to spasm. A spasm frequency score of 3 means more than 1 but less than 10 spontaneous spasms per hour. And you might see this occurring, for example, somebody sitting outside in short pants, the wind just breezing along the hairs on their leg may stimulate a spasm. And then a 4 is where you have more than 10 spontaneous spasms an hour. This is where we start to run into problems, 3s and 4s, but more so the 4s because it could herald significant problems, kicking the person out of their chair, keeping them awake at night, etc. So this is the Penn spasm frequency score. It's completely separate from the stretch reflex exam, although as you see, increased Penn spasm frequency scores of 3 and 4, typically that's going to relate with hyperreflexia 3+ and 4+ clonus. So typically as we talk about clonus, what are we trying to explain there? So usually reflexes we call normal reflexes 2+. And so if you tap with the reflex hammer, you're going to see a certain, dampened reflex activity. A 3+ is fairly brisk reflexes, and 4+ is where we see clonus. So we go into this back and forth rhythmic contractions, and it's really nothing more than activation of muscle groups on both sides of a joint. So you're stimulating Sherrington's spinal common pathway when you push the plantar flexors into a dorsiflex position, you put them on stretch, they in turn are going to contract reflexively, which puts the dorsiflexors on stretch, and they in turn are going to contract reflexively. And so you have this on both sides of the joint, and we talk about having sustained clonus as we go through there. You may also have long track signs. For example, as you do your Babinski maneuver, you see an upgoing toe in response to that. That indicates an upper motor neuron injury with disinhibition of reflexes and particularly these types of maneuvers. Now, the equivalent in the upper extremity is the Hoffman's reflex. So basically, you flip the middle finger and you see the thumb typically will contract in response to that. And again, this is a long track sign of the cervical cord. So as we're looking at that, you may have both upper and motor neuron and lower motor neuron findings in the upper extremities if you have a positive Hoffman's. So the Ashford scale has been around since 1989, however, has been pretty much put to rest, and we use what we call the modified Ashworth scale instead. And so when I am reporting out on my clinical notes, I will report out a modified Ashworth score looking at 0 being no increase in tone and a 4 being so much tone that the affected limb is essentially rigid in flexion or extension. And then we have gradations in between. So 1 is where at the very end of the range of motion, I get a slight catch, but really no significant increase in tone until at the very ends of the range of motion. A 1+ is where I have a slight increase in tone throughout the range of motion, but I get a catch partway through. And so this, and again, remember, this is velocity dependent tone. So that would be a 1+ Ashworth scale, modified Ashworth scale. A 2 on the modified Ashworth scale is a marked increase in tone through most of the range of motion, but I can still easily move this limb through the range of motion. A 3 is considerably increased tone, and I can get it through its full range of motion, but it's somewhat challenging for me to do that. And then a 4, again, is associated with rigid limb caught in flexion or extension. Now, it's important that oftentimes they will go in hand, but when we talk about contractures, contracture for a muscle is basically the sarcomeres in that muscle have been shortened, and ultimately we have fewer and fewer sarcomeres in series. And so if we have that much tone at a limb, then in order to regain the length of the muscle, we're going to have to modify the spasticity, that is the tone in that muscle, and then go through a series of stretching and hold, stretch and hold. So we'll talk about serial casting in just a few minutes. So we've looked through basically the history of the spasticity and tone. We've talked through the reflex examinations. Now let's talk about active motion and functional evaluations. Active motion, now I want the person to move their limb on their own as they're going through their range of motion to see how much they can overcome against gravity. Now, sometimes the tone is so great in the antagonist muscle group that they can't get through the full range of motion. And yet, they might have anti-gravity strength. And so one of the tricky things as we talk about managing spasticity and then we look about motor recovery, sometimes if I manage spasticity and I basically unmask a person's anti-gravity strength, you might be thinking that they have gained some motor function, where in fact, all that has happened is we've reduced spasticity by the antagonist muscle group and allowed that person now to move against anti-gravity because we've eliminated the tone that was holding them back in the first place. So it wasn't truly that they were weak and had an anti-gravity strength. It was that they were not able to overcome the tone of the antagonist muscle group. So keep that in mind as we go through this. The active motion is essentially allowing me to see what the person can do under voluntary muscle contraction. And again, I try to tease out how much of this is truly anti-gravity, how much of it is being limited by antagonist muscle groups because of spasticity and tone. And then I want to do a functional evaluation. Does the hypertonicity interfere with self-care? For example, doing perineal hygiene, intermittent catheterization. If you have such adductor tone that you can't open your legs, that's going to be problematic. You're not going to be able to maintain appropriate hygiene, perineal hygiene, for example. If your hypertonicity interferes with sitting or standing balance, if it interferes with mobility, then that's not good. Now, what just happened there? Dr. Gator got slapped, yes. When I was an acting intern, a fourth-year medical student, I had the opportunity to be under the tutelage. The chief resident at the time was John Dorsett. He was a fourth-year resident at UC Davis, and John was a former gymnast who had a C7 Asia Impairment Scale C tetraplegia. And so he used a wheelchair to get around. And he was my chief resident when I was a fourth-year medical student, you know, hot to trot, ready to show how much I knew. And he sent me to do a consult on a patient on the acute floor, and I came back, and I had all of these things listed out, as I would expect you guys to be able to do. And as I got to spasticity, he said, well, how much spasticity does the person have? And I said, oh, it's, you know, a modified Ashworth of 2 or 3. It's kind of in between a 2 and a 3. And he said, well, you know, what is it? And I said, okay, I'll call it a 3. He goes, what are you going to do about it? And I said, well, I was going to start him on baclofen. And that's where he slapped my hand. And I was taken aback. I was shocked. And he said, Dr. Gator, I wasn't a doctor yet, but he was very respectful. Come with me. And so he wheeled into a room, set the brakes on his wheelchair, and he slapped his thighs and stood up. And I was like, oh my God, this is a miracle. Because I really hadn't worked much with spinal cord injury patients yet. And he stood at the bedside, he did his functional examination of his patient, and then he turned just a little bit and he fell right back into his chair. And then he wheeled out of the room, and I followed him with my jaw on the floor. You know, I was shocked. And he said, that is something that you have to keep in mind before you treat spasticity, because if you were to put me on baclofen, I wouldn't be able to do my physical exams at bedside anymore. I rely on my tone to allow me to stand at the bedside, and it dawned on me, wow, yes, spasticity can be a good thing, spasms can be a good thing. So I've kept that with me ever since. John Dorsett. Wonderful man, still at UC Davis, by the way. So we just had this lecture recently on autonomic dysreflexia, and we talked about all of the different things that could contribute to autonomic dysreflexia. Nociceptive input. Now recognize that nociceptive input is simply afferent information, and that afferent information is also going to influence excitatory postsynaptic potentials and therefore increase spasticity. So all of those same things that we saw causing autonomic dysreflexia can cause spasticity as well. And below T6, it's the only thing that you'll see is just spasticity and not significant tone above. So let me just ask for a moment. I'm going to pause and say, how come there are some folks who don't have significant spasticity? They have paraplegia. They're clearly out of spinal shock, but they don't have any spasticity or spasms. Anyone? Particularly lower levels of paraplegia. And I'm going to come back and I'm going to say, because we have interrupted Sherrington's spinal common pathway. So these are the folks who have peripheral nerve injuries, cauda equina injuries. They have a flaccid paralysis instead of a spastic paralysis. And at lower levels of spinal cord injury, so L3, L4, and below, you oftentimes have a conus medullaris type of syndrome and or cauda equina, in which case you have interrupted either the afferent or the efferent loop of Sherrington's spinal common pathway, and you no longer can have a reflex. So I'm just bringing that back to mind. When do we treat? We make sure that it's not going to interfere with the person's functional abilities, and then we consider to what extent does this interfere with the person's activities during the course of the day or at night. Is pain a factor as well? So the typical stepwise approach would be to look at stretching, positioning, and serial casting. Additional modes including cold application and TENS, oral pharmacotherapy, subsequently intrathecal pharmacotherapy, neurolysis, and then surgical interventions, going from least invasive to most invasive as we go up the steps. This is who? Out of the Fantastic Four, is Dr. Yaros on this call? I would expect him to know this is Reed Richards. Not Reed Yaros.
Yes.
Yes, Reed Richards. They share the same first name. Dr. Richards may be a little bit more flexible than Reed Yaros. I haven't checked his spasticity yet, but anyway, we realize that passive stretching can be helpful to reduce the gain of the spindle system, but it only lasts for up to an hour or two, and then the spindle starts to regain its usual tone. So stretching twice a day generally isn't going to be significantly beneficial to somebody who's got a lot of spasms and hyperreflexia. But if they can stretch multiple times a day, say 6 times a day, and maintain their function, I'm okay with that. It's just not many people are able to manage their spasticity very effectively that way. Posture and positioning in a wheelchair. So again, all kinds of things can set off additional spasticity. And sometimes, most times, folks with spinal cord injury will end up with significant degenerative changes in their spine because of the constant pounding for folks who don't have the usual muscular control to maintain or cushion the pounding. And so they end up developing what looks like ankylosing spondylitis, significant degenerative changes, pretty much a bamboo spine, and you'll see that in most folks who have had an injury for 5 years or more. You take a look at their spine x-rays and they look really ugly. So a little bit of facet arthropathy or a little bit of degenerative changes in the spine can cause you or I pain. For them, it just causes autonomic dysreflexia or spasticity. And so keep in mind, trying to maintain appropriate posture in the chair is going to minimize the likelihood that they're going to have some sort of a nociceptive input because of inappropriate alignment as they go through this. Cryotherapy is the application of cold. Recognize that if this is prolonged, it could also potentially cause skin damage and burns. And so we have to keep in mind as we go through this. But this will also reduce the gain of the spindle fibers. And yet, unless you're going to do it multiple times a day, it's usually not a practical way of managing spasticity. Electrical stimulation. And in this mode, we're going to have a whole separate lecture on electrical stimulation, but TENS, the transcutaneous electrical neuromuscular stimulation, can reduce pain, essentially through white noise. We'll talk about the whole Melzack and Wall gate control theory. It's not gator control, it's gate control theory of pain. But basically, by reducing pain, you're reducing noxious stimuli that could be contributing to spasticity, increasing EPSPs. And so this is another not so shocking revelation to us that it could be helpful to manage spasticity as well. Oftentimes, though, we resort to pharmacotherapy. And so I'm going to talk through the applications of GABA agonists, alpha agonists, and dantrolene as we go through these. So in the first category, lioresal is the one you know as baclofen. It's a GABA analog. It's a GABA B analog in particular. And it has a half-life of around 3.5 hours. Typical starting dose is 5 milligrams TID. The physician's desk reference says don't go above 80 milligrams a day. I'm a little bit more liberal when it comes to using the oral medications, and occasionally, not very often, have taken folks up as high as 60 milligrams 4 times a day. Don't recommend it. If you're going to do that, typically I'm looking for changes, somnolence, and those kinds of things. But as they tolerate, I will titrate it upward. And it also gives me a clue of those folks who may benefit from intrathecal baclofen. Back in the day, we were just starting to use baclofen pumps, and so we had moved up to these higher oral doses. Usually I don't go this high anymore, but occasionally I will do it as a starting point to see how well the person might respond to intrathecal baclofen. Recognize that if you're going to do this and titrate upward, you also have to keep track of liver function tests, which may be influenced. You can cause a transaminitis with lioresal as well. The side effects include sedation, fatigue, and relative weakness. When I say relative weakness, what I mean is those folks who have been using their tone to facilitate functional tasks may now report when they start using lioresal or baclofen that they're not able to functionally do what they could do before. And again, it doesn't mean that they've lost strength. What it means is they no longer have that tone assisting them. So you want to try to ferret out these differences as you go through there. One of the key things with the use of lioresal baclofen is that it does decrease the seizure threshold. Recognize if you have an abrupt withdrawal and you've had somebody on 20 milligrams QID or more, they could go into seizures. And so keep that in mind. They may also be seeing hallucinations. This can occur both with oral withdrawal as well as intrathecal withdrawal. If somebody has a baclofen pump and for whatever reason they can't get it refilled, you can resort to oral baclofen to keep them from going into withdrawal in the interim. And so that's another one of those pearls you need to keep in mind. This medication looks almost the same, diazepam, vitamin V, basically, Valium. And as opposed to lioresal, this is a GABA A agonist. And so it also, both of these increase inhibitory postsynaptic potentials, okay? They're going to increase the IPSPs and therefore decrease the amount of hyperreflexia and spasticity, as well as spasms as you go through this. Diazepam is a little bit more sedating, so you have more of the CNS cognitive dysfunction associated with it than you do with lioresal. But it can be helpful if I've got a person who's only having problems with nighttime spasms, having difficulty sleeping, I will put them on a low dose of diazepam just at night to manage their nocturnal spasms. Again, side effects include sedation, hypotension, depression, potential weight gain with both of these. Why would that be the case? Our folks who have spasticity and spasms are burning calories every spasm that they have. And when you stop spasming so much, they don't burn as many calories. And so there can be significant changes in their weight as you add on anti-spasticity medications. So keep that in mind. Now, a quasi-GABA agonist is gabapentin, which actually doesn't interact with the GABA receptors. What? That's what it was named for. But it doesn't. And it doesn't significantly increase IPSPs directly. However, gabapentin will reduce spasticity. Well, how does that happen? It might be through voltage-sensitive calcium channels, or it might be that we know it works well for neuropathic pain. And as you decrease neuropathic pain below the level of the spinal cord injury, you decrease that nociceptive input, and yes, you're going to see a reduction in excitatory postsynaptic potentials, okay? So in that case, what we're seeing is not an increase in IPSPs, but a decrease in EPSPs. And I want to segue into other medications that can decrease EPSPs. So alpha agonists, such as clonidine, its mechanism of action is to decrease the excitatory postsynaptic potentials. Okay, this works completely differently than the GABA agonists, which increased the IPSPs. The alpha agonists decrease the EPSPs, and so you can use those in concert fairly effectively because you're working on different mechanisms of management here. The problem with catapress or clonidine is that, mostly it's been used as an antihypertensive agent. And so it's not unusual to start this and immediately have folks have difficulty with additional neurogenic orthostatic hypotension. And so for those folks you got them on fluornephromidodrine, probably not a good medication to trial with. You might try instead xanadine, which is also an alpha agonist. It decreases the EPSPs, but it has less side effects in terms of causing hypotension. And so it's a better agent to use as opposed to catapress or clonidine, for example. What about dantrolene? I don't usually prescribe dantrolene in spinal cord injury. It can be a great medication for spasticity associated with brain injury and or cerebral palsy. But because of its action, what is its action? It reduces the release of calcium from the sarcoplasmic reticulums. And therefore, at all muscle groups, even those that the person has voluntary control over, you're going to lose strength and not just manage spasticity. The other side effect that you need to worry about is, again, the transaminitis, the increased LFTs associated with its use. The other time that you use dantrolene, the first time that I used it, I didn't know about spasticity. All I knew, there was this patient who had come in with malignant hyperthermia. And I was told, oh, use dantrolene to manage that. And I didn't realize that the reason it worked was because the person's malignant hyperthermia was because of continuous contraction of almost all the muscles in the body. And so the dantrolene took care of that, and yes, their body temperature came down. So anyway, it's another way of doing this. I mentioned the cognitive side effects associated with higher dose of lioresal or baclofen. One of the things that we can do is deliver the baclofen or the lioresal to a space where you don't have all these cognitive side effects. So if you put it into the intrathecal space and let it float down in the cerebral spinal fluid, basically this will provide the same sort of inhibitory postsynaptic potential activation that we're talking about. And so the IPSPs associated with intrathecal baclofen are basically right there at the spinal cord level now. It's being bathed with this, and so you end up having IPSPs as a result, and it reduces the spasticity. And some people say, well, yeah, but one of the drawbacks is you can't go above, say, T5 or so in terms of the administration of the medication, because you worry about it depressing pulmonary muscular function, et cetera, et cetera. And so they say it's not good for folks who have upper extremity spasticity and tone. Well, it is actually. You just need to have them tilt back intermittently during the course of the day. And as they do that, the baclofen that's in the CSF will actually start to bathe the upper parts of the cord, the cervical regions of the cord as well, and then they can come back down. And so they will get a response to that, and you'll see a significant reduction in tone in their upper extremities for the next 1.5 to 2 hours after they've tilted back for a period of time. So it's still, you can use this for upper extremity tone as well, is all I'm saying. Typically, we will do a screening trial. I am, again, fairly liberal in terms of doing these trials, and I'll either go with 75 or 100 mics for my screening dose. And basically what we're looking for is a 2-point drop in the modified Ashford scale at uppers and or lower extremities. Typically, I'll have PT and OT on board to evaluate this as well. So this would be ideal to be done, for example, in our outpatient clinic. And then we can have our outpatient therapists continue to monitor not just spasticity and modified Ashford scales, but also functional tasks. Because if I can see a significant improvement in perineal hygiene with this dose, but I don't see a necessary 2-point drop in the modified Ashford scale, I can still provide medical justification that this is going to be a good way to go. So these are the contraindications. I'm sure you're going to get many more lectures on intrathecal baclofen. Of note, I was shocked and surprised that we didn't have a baclofen pump programmer in the rehab hospital or rehab center. I think that that's being fixed, and we should have one within the next couple of weeks is what I was told. But we should always have one on the floors and one in our outpatient clinic. This is very, very important to be able to modify dosing and to do a pump refill if it becomes necessary. So again, without going into a lot of detail, all of you should be very familiar. If you're not yet, make sure you sit down with the seniors and talk through the use of the programmer so that you know how to modify, how to interrogate a pump, and then modify the dosing as necessary. Basically, the pumps are set so that it's about the size of a hockey puck, and in the center of that, you have a rubber, essentially, that you can pass a needle through and be able to withdraw the medication and then refill the pump as you go through that. So we'll talk you through that at a different time. Essentially, again, trying to provide intrathecal delivery of baclofen as we go through there. So the benefits, you don't have to have as high a dosing, and you can go as long as 3 months. What? Go as long as 3 months. You don't have to take medication several times a day. But the baclofen pump will deliver the right amount of medication. You can modify it so that it delivers more during the course of the day when the person needs it, or less during the course of the day and more at night when they need it. So you can modify how much is delivered at different types of day. And this is one of the real gifts to folks who have significant spasticity, to be able to manage that in a much better way. Nerve blocks, neurolysis, basically, we can use phenol, but I only will use phenol in non-mixed peripheral nerves. Why? Because a mixed peripheral nerve has both afferent and efferent fibers running through it. If I hit those afferent nerve fibers with phenol, it will cause significant pain, neuropathic pain, and I shouldn't do that. So most notably, this is very helpful for the adductor muscles, the obturator nerve sprigs that are primarily motor, and you don't have to worry about sensory or neuropathic pain being associated with this procedure, but it's not a good fix for most other muscles, most of whom have mixed both sensory and motor fibers coming to them. So hopefully this is a Botox video. We'll see if it comes up, and if it doesn't, I'm going to try to go back and it was there a little, it really was there a little while ago. I'm going to try it one more time. We'll see if I can go back. No. Oh, there it is. It's maybe not going to work. It should, oh, there it is. Let me just try this. This is how Botox works.
The presynaptic neuromuscular nerve ending contains membranous vesicles prepared to release its stored neurotransmitter, acetylcholine. Neuronal stimulation initiates a cascade of events that leads to the fusion of the neurotransmitter-containing vesicle with a nerve membrane. This process is facilitated by a group of proteins comprising the snare complex. The membrane fusion results in the release of acetylcholine into the synaptic cleft by a process of exocytosis. The acetylcholine diffuses and eventually binds to receptors on the muscle, leading to muscle contraction. Botox, botulinum toxin type A, consists of a heavy chain of 100 kilodalton and a light chain of 50 kilodalton, making up the 150 kilodalton core type A molecule. The toxin is protected by accessory hemagglutinin and non-toxic non-hemagglutinin proteins, yielding a uniform 900 kilodalton complex. This illustration shows a cross-section of the spine, with a motor neuron extending into the muscle and a sensory neuron extending out of the muscle. After injection of Botox, it would be expected that most of the neurotoxin would remain at the injection site. The Botox core molecule dissociates from the accessory proteins and targets the nerve endings. The binding domain of the Botox core molecule is the C-terminal portion of the heavy chain, with an acceptor on the nerve. The Botox core molecule enters the nerve cell by a process of receptor-mediated endocytosis. It is the heavy chain that contains the binding domain. The toxin is now contained in a membranous vesicle inside the cell. Soon after, the light chain is released into the cytoplasm of the nerve terminal, where it begins to cleave one of the snare proteins. In motor neurons, the light chain of the Botox core molecule blocks the release of acetylcholine by cleaving SNAP25, which is an essential component of the snare complex. When acetylcholine cannot be released, muscle contraction cannot occur.
All right, so that was the key. Just a reminder, this is a presynaptic management of spasticity, as opposed to trying to provide something either postsynaptically or as we modify. Remember, all axons are all or none propagated axon potentials. And so EPSPs, IPSPs before that, all of this will contribute to, are you going to have release or not of acetylcholine from this particular nerve group. So the onset of action may take 2 to 4 hours. A peak effect of Botox, 2 to 4 weeks. Duration of action is somewhere around 3 to 6 months. And you can localize it with EMG. However, you can also just inject it into the muscle if you know that you're in that region. I advocate, particularly if you're trying to go for a specific, let's say you've got somebody who's having difficulty walking because posterior tibialis activation, too much spasticity in that particular muscle, to be able to activate it with neurostimulator and then know exactly where to put the Botox is going to be very, very helpful to you. There are some side effects, however, to Botox, and so you have to recognize that once you've administered this, this is going to maintain for the next 3 to 6 months or so. whether you use that at skeletal muscle, whether you use that at the bladder. All of these things are going to basically be interfered with. You're going to have paralysis of that muscle until such time as the toxin is no longer available and you no longer have cleaved all of those snare proteins as you go through there. Finally, there's surgical management. And so irreversible ablation isn't always irreversible, but mostly the afferent tracts. And so selective dorsal rhizotomies, not usually associated with managing spinal cord injury or spina bifida. More commonly used, you're going to see this in children with cerebral palsy, whose spasticity is so out of control that functionally they can't do anything and you can't seat them appropriately. But usually we're not going to see this as a management strategy for folks with spinal cord injury. So, in summary, we kind of went through our definitions, the epidemiology, the anatomy, hopefully helped clear that up, why more people with paraplegia have less spasticity, particularly as you go lower and lower injuries, why people with higher levels of paraplegia and cervical tetraplegia are more likely to have increased spasticity and tone. We've talked through, I hope you will remember, not all spasticity is bad, and sometimes by treating spasticity, you could potentially take away a person's functional abilities. So keep that in mind. That's also going to reduce muscle tone. Subsequently, you're going to have more sarcopenia, and metabolic rate is going to drop further and further. So there's a balancing act that we need to do to maintain a certain amount of tone, a certain amount of energy expenditure, so that we don't end up with obesity, which is one of the things that I try to combat as much as possible. So that was kind of an overview. I'm welcome to take any questions, thoughts, concerns. You can either do it by chat or just unmute yourself and bring this up. So early on, as we see, we're starting to manage somebody with significant tone and spasticity. We get them at a stable dose, we think, and then the next week they have a sudden increase in spasticity. What would you be thinking?
Possibly infection.
Okay, so possibly an infection, some sort of a noxious stimuli below the level of the injury has now propagated itself and is increasing EPSPs. And so it doesn't necessarily mean that I need to increase my spasticity medication. I need to go hunting for the cause the same way I would go looking for a cause in autonomic dysreflexia. Riddle me this. What about a relatively young woman who we just got her controlled, and then you send a UA CNS, she's got increased spasticity, and it comes back normal. Doesn't look like she has that. What else could be causing her
Could it be
spasticity?
menstruation?
I'm sorry?
Menstruation?
Yes, middle schmerz. And again, going back and getting a history, recognize that some women at that point of ovulation, they actually have pain associated with it. And that used to bother them all the time. And now they don't have the pain anymore, and they're just delighted, except their spasticity really bumps up once a month or so for approximately 3 to 5 days. And so exactly, that's a potential cause. Another potential cause is, pregnancy could be causing this as well. And I've had patients who didn't realize they were pregnant and were having Braxton Hicks contractions, causing spasticity and in one case, autonomic dysreflexia. And then we found out, oh my goodness, why she's pregnant. Go figure. So yeah, be thinking through, because all of this is the result of noxious stimuli below the level of the injury. If their injury is below T6, it may not kill them, but it can significantly increase their spasticity and tone, and it tells you something is going on below the level of their spinal cord injury. All right. Additional thoughts, questions, concerns? All righty. Thank you for your time and attention. Everybody have a great day. I'll see you later.